All right, so we can go ahead and begin. So, welcome everyone to today's shadowing session. Today we have Dr. Keerthi Keshavarapu. I hope I pronounced that correct. And she's a gastroenterology fellow. So, welcome.
Hello, thank you for having me.
Yep.
All right, so hello everyone. I'm so excited to be here and just kind of tell you a little bit about my journey into medicine and GI, and also maybe some tips that might help along the way as you guys kind of go through that journey as well. So a little bit about me. I grew up in Atlanta, Georgia, went to undergrad at Georgia Tech. Was a BME. Initially, I started out as BME, ended up graduating with biology, and then went on to medical school at Philadelphia College of Osteopathic Medicine. I took an alternative route to medicine, and I'll talk about that a little bit more later. I went on to Philadelphia, and started residency at Drexel for internal medicine. I started fellowship at Drexel as well, but our hospital shut down, and 580 of us were displaced. So we reapplied, ended up matching at Temple, which is also in Philadelphia. So, this was a difficult time for us. We were battling in the courts for our rights as trainees. And this is a difficult time for you guys as applying to medical school and residencies, not being able to have all the experiences that you would have otherwise. But I think something that you take away from this is that, you come out stronger from these kinds of experiences. These are stories that you'll have for the rest of your life. And I think this is a good experience for you to go through. Even just the creation of this organization, it's great that this came out of a necessity and you guys were able to fill a need that people had because of COVID. So you guys are definitely coming out of this whole COVID situation stronger for it. And during this time, I realized I was interested in obesity and nutrition because it's so important in diseases of today, and so little is taught in the current medical school system. So I did an obesity fellowship with the American Board of Obesity, and I'm now applying for a nutrition fellowship to kind of supplement that as well. But after all of these years, 10 years, finally got my first job. So I will say medicine is a long, long journey, definitely not for the faint. So we're super excited. My husband and I are both going into academic medicine in New Jersey, and we'll be taking a position of obesity and nutrition specialized within our own GI and endocrine. So tips, if you're a college student, in terms of what I get asked a lot from people, choosing your major. Is it important to have a particular major? And in my opinion, all that matters is how well you do in your major and that you're interested in what you're choosing to do. So you don't have to do biology or neuroscience. You could be anything. You could be basket weaving. You could be public policy, international affairs, anything that really interests you, makes you stand out. And if you decide to do something that's not in the field of biology, this can be something that you talk about in your personal statement or during your interview. So definitely adds to your application, but I don't think it necessarily matters what you choose as long as you do really well. The most important things when applying to medical school are going to be GPA and MCAT for sure. These things definitely matter. That being said, if you don't do well in one area or the other, explain yourself in your personal statement or via an email so that the program kind of understands. How did I know? I will address that in a second. Yep. Yep, I'll answer that too in a minute. So basically, I would say explain yourself so that people understand why you didn't do so well in a particular, whether it was your GPA or MCAT. Stand out with your activities. So when you're choosing kind of what activities to get involved in, you don't want to just be a participant, but try to get a leadership role or start an organization or an activity at your particular college or medical school. These things make you kind of stand out. And again, these are great things that you can talk about in interviews and personal statement. when it comes to research, the most important reason for research at this time in college is more so to kind of create a relationship with your researcher, your research preceptor, so that they can write you a good letter. And I think that's why research is important. It's very rare that you see someone at this stage kind of come doing, some really big project and get a paper out of it. It usually takes time. I did bench research at Georgia Tech by just cold emailing various professors in the biology department and kind of asking who had an availability, because initially I didn't know what area I was interested in. And then I ended up doing clinical research at Emory. Again, that was also by cold emailing various professors at Emory as well, and seeing who research was interesting, who had an availability in their lab and things like that. And that project ended up eventually coming up with a book chapter and a paper. So, it takes time. And when you're in this process of looking for researchers, essentially what you want to do is you want to make sure you send them your CV and write a letter or an email expressing your interest, and make sure that you show interest when you're doing the project, meet deadlines, make your preceptor's life easier. And one important life lesson that I learned during this time is people are super busy. So don't be offended if they don't respond to you the first time. Send them another email. Be persistent without being annoying. And it's definitely a balance, but just because someone didn't respond doesn't mean they're not interested. Maybe your email just got pushed to the bottom of their to-do list. So definitely just send them another email. And all of this is to say you want to have strong personal letters, strong letters of recommendation. So all of these things you're doing, you're establishing relationships with various preceptors who can then write you a very strong letter. And I'll give you an example of a friend of mine who was applying to medical school in college, asked for a letter, and eventually down the line she was able to see the letter, and the person that wrote the letter had wrote him instead of her in all of the pronoun spots. So you can tell this is someone that didn't know them very well. They used a standard template and didn't change the gender of the person applying. So you don't want letters like that. Shadow, in this particular situation, you want to take advantage of virtual shadowing experience as much as you can. Choose opportunities that are very interactive. This is a great spot. You're able to ask questions. You're able to go through cases. There's other opportunities as well. I think pretty soon you'll see that things are going to be opening up again. You guys will be able to kind of go in person. So I think that will be changing soon. I'm hoping in the next 4 to 6 months, you'll see a big difference. And then personal statement. I get a lot of questions about personal statement. Honestly, all that matters at the end of the day is that you write a personal statement that has good flow, has good grammar. And that's all that's important. And kind of explains why you want to go to medicine. What you write, how you start out, whether you use a personal story or not, whether you use a quote, none of that really matters, to be honest, as long as it's a well-written, well thought out essay. Okay, let me into the chat box real quick. Okay, so some of you guys asked about DO schools. So there's 3 alternatives. You didn't get into medical school. What are the other pathways that, to get into medicine? So one of them is DO school, so doctor of osteopathy. 11% of the current physician workforce is DOs. They have the same medical school curriculum requiring board certification with additional training in OMM. So the only difference is you add on an extra class. There's 2 parts to that class. One is a lab where you're hands-on and you're interactive and kind of treating each other and learning procedures off of each other. And the other one is kind of learning techniques using a book. You're in a class, you're sitting and kind of lecture based. In terms of, if you're going to use these procedures in real life, it depends on where you go, what areas you go into. So you can imagine people that work in musculoskeletal system are probably going to use it more. So OMM is an evidence-based hands-on therapy to diagnose, treat, and prevent illness and injury. So here you can see someone doing what's called high velocity HVLA, high velocity, low amplitude technique. Essentially, he's cracking her back. And as anyone knows, if you've ever had your back cracked, it feels good and kind of relieves some tension in your back, but you can use it for a lot of other reasons. You can use it for visceral issues, like, for example, colonic stimulation if patients have constipation and want to have a bowel movement. So those are two types of techniques that people can do. The other options you have are post-bac medical school programs. So essentially, this is if something was lacking in your application the first time, whether it was a GPA or research or something like that, these programs will in 1 year kind of help you with your GPA. And there's various programs. Some of them feed right into medical schools. So here's a list of them at the AAMC. And the third one's foreign medical schools. So if this happens, of course, shoot me an email. We can talk about it and kind of review the options and what's the best for you. One of the questions I frequently get asked is, so when you're applying to DO schools, you need a letter from an osteopathic physician. And that can require at this time, you're not really able to shadow. One of the things that I often suggest to people is contact your local DO school, send them an email or a letter or a call, and sometimes you can observe their OMM classes. And that can lead to kind of establishing a relationship with the DO program there. And, you can kind of go down that path. And I would also ask, medical schools right now when you're applying, hey, I wanted to shadow a DO, I wasn't able to find one. I came and did this experience at the medical school. Is there any way that I don't have to have that kind of letter? Go through the chat and just answer questions about DO schools. What's your experience been being a DO? So far, it's been good. My biggest concern when I first started, applying to residency and fellowship was what is the stigma behind being a DO? And I think that there's some areas of the country that are where there's more of a stigma, and some areas where there's less of a stigma. In Philadelphia in particular, there's a lot of DO physicians here, and there's been very little stigma that I've had to deal with, especially applying to residency. So I've overall had a pretty good experience. It hasn't limited me from getting into any programs or matching into fellowship or anything like that. The biggest difference between how DO and MD doctors interact with each other, I think in theory, you would think, because osteopathic physicians are taught to work with their hands, they have a great understanding of the musculoskeletal system. And that's true. We definitely do. But I haven't noticed that my MD counterparts at work are lacking in that field. So I think overall, while we do, have a great mastery of the anatomy and working, with our hands and understanding musculoskeletal system, I find that, overall, we both do a great job working with patients. I'll to the rest as we get to them. So the journey to GI, as you guys know, medicine is a long journey. You start with high school, college for 4 years, med school for 4 years, internal medicine residency for 3 years, and then GI fellowship for 3 years as well. And then I did an obesity fellowship, and I will do a nutrition fellowship as well. So definitely a long, long journey. And there's a lot of sub-fellowships of GI. Like I mentioned, I'm interested in nutrition and obesity, but you can also do inflammatory bowel disease, motility, which deals with the actual movement of the gut, advanced gastroenterology, where the focus is the gallbladder, bile ducts, so the plumbing tree, pancreas. So they do more advanced procedures, and I'll go into that in a little bit as well. And then hepatology, which mainly deals with the liver. So why did I decide to do GI? I mean, I think what's really important when you're choosing a specialty, whether you realize it or not, is the interactions you have. So when you shadow or you do rotations, you experience all areas of medicine and surgery, and you notice certain preceptors or certain educational opportunities that you really enjoy. And then that, I think, kind of gears you into where you want to go. So for me, I started out residency on a hepatology rotation and absolutely love the pathophysiology of the liver. It's a very complex organ. It kind of deals with a lot of our basic systems in our body. And these are patients that, you get to know over a long period of time. You kind of provide all types of care for them. And I really enjoyed, that was my first foray into GI. After that, the reasons why I really liked it is I knew I enjoyed working with my hands and wanted to do procedures. But I also wanted to follow patients for a long time and really kind of get to combine patient care and procedures. And, there's a few areas of medicine like that. I would say OBGYN, urology, but GI is one of them. And I think the other really cool thing about GI is it's on the forefront of innovation right now. There's a lot of procedures that we're kind of adapting from surgical procedures where you had to undergo like an opening of your body from the outside, we can now do internally. And so it's very, very cool. So some of the things that GI doctors do, as you know, mouth, esophagus, stomach, any kind of diseases in there. We deal with the small intestines, the colon. We're also involved in the liver, the gallbladder, the pancreas, and then the plumbing tree that drains all of those organs with bile ducts. We now are kind of in the forefront of managing obesity. So, predominantly surgery used to be the mainstay, and it still is the mainstay, but we're now coming up with tools of treating obesity endoscopically. So instead of cutting someone open and surgically working on your people's stomach, we can now do it through a camera test through your mouth. And so this is one of them where we suture the stomach into a smaller size. This is one where we put in these balloons that helps people feel full and eat less. We also, one of the biggest things that we do in the inpatient side is we treat GI bleeding. So if people are bleeding from the GI tract, we find it and we stop it. It's very rewarding. We do colonoscopies. We do colon cancer screening, which is kind of the biggest thing that GI doctors are known for. We identify polyps, we take them out, we identify cancers, and we can also take out some cancers. We also do a camera pill cam test where if you're bleeding from your small intestines or have any issues in your small intestines, you swallow this small pill. It takes 10,000 pictures. And then we can identify, looking at those pictures, what's going on in your small intestines. We do endoscopic ultrasound. So we can do an ultrasound inside your body, identify cancers. We can go into this plumbing tree here and treat and diagnose cancers and take out stones. We identify motility problems within your GI tract. And we put in feeding tubes, so we help with nutrition. So what does a GI fellow do? So we see patients in the hospital. We do procedures in the hospital. We see patients in the clinic. We do outpatient procedures. We work on research. We teach medical students and pre-med students and residents and first year fellows. I'm also interested in social media education and medical writing. So before I start on the cases, I'm just going to go through everyone's questions. Okay, so the first question, how did I know I wanted to pursue GI? For me, it was all about, combining working with my hands and doing procedures, but also having that patient care. But I think as you're deciding to choose a specific specialty, really it's about the experiences you have. So it's really important that if you think you might be interested in it, do a rotation, shadow an attending or a physician that does that. I think that's the best way to really know if that's something that you'd be into. Is it difficult to balance work and life outside of medicine? I think before, so the physicians that were, that are now in their 60s, 70s, 80s, back then your life was medicine and that's it. Now I think the burnout is so high for so many different reasons that you have to have a life outside of medicine. It can get pretty exhausting if you don't find that balance. And I think it takes time, but you have to make sure that you take time for yourself because it can be very draining. So for me, I make sure that I do something for myself every couple of days, whether that's seeing somebody, going out, having fun, making sure that you take all your vacation days, travel, before COVID and COVID goes away, keep social, see your family, see your loved ones. You have to make sure that you stay balanced. And it's definitely easy to do that once you're an attending, because you can really create the life that you want. When you're a trainee, it can be a little bit more difficult. The first year of each level of training can be really tough, but the subsequent years get easier. It's definitely possible. In medical school, I would say that was, you're mostly studying, you're stuck at a desk for the first 2 years, especially as you're studying for step one. And that can be a little bit difficult, but to make sure that after every test, you kind of blow off some steam, go somewhere, do something fun, hang out with other people. That's kind of how I blew off steam. What is the most common types of issues patients face in the field of GI and nutrition? So most common things are going to be bleeding. That's what GI doctors do, mostly in the hospital. And as an outpatient, it's colon cancer, screening and diagnosis, and polyps. And then I would say the third issue is foreign body and food impaction. So things getting stuck in your esophagus. Best ways to avoid acid reflux. So dietary is the best way to start. You want to identify triggers. So a lot of people have food triggers, things like onions, tomatoes, garlic, alcohol, smoking, identifying what your risk factors are, what causes your reflux, and then avoiding them. You want to make sure that you don't eat within 4 hours and then within 4 hours of laying down, so that food kind of has its way to work its way down before you lay down, because as you lay flat, things kind of reflux right back up into your esophagus. So that's the best way to kind of start. And then if those things aren't helpful, then you kind of start to transition to take medications. But you want to try to do as much as you can without medications initially. My first question is, how many fellowships can you choose after your residencies? So usually people will go from residency to one fellowship. And if there's something that you're further interested in, you can do another fellowship. So within that field. So if you do like medicine, you'll choose one of, nephrology, gastroenterology, cardiology, you'll pick one of those. And then some people will choose to go further. And in cardiology, there's many sub-fellowships. In GI, there's sub-fellowships. So it'll really depend on what kind of job you want, how niche you want to be. My second question is, what are some common procedures you do in your daily practice? So the two most common things I do every day are endoscopy and colonoscopy. And that's endoscopy, where I go in through the mouth with a camera test into your esophagus, stomach, and small intestines. Colonoscopy is when I go in through the butt into your colon and a little bit of your small intestine. How does the process work after a primary doctor recommends a patient to you? Sure. So a primary doctor will send a patient to me once they realize if they think a patient needs an endoscopy or a colonoscopy, usually, or they have a symptom that they haven't been able to manage with the usual medications. And then they'll come to me, we'll, work them up, whether it's procedures or further medication. I hope that answers that question. How has fellowship training helped you in your career in internal medicine? So it's usually once you've done a fellowship, that's what you'll practice in. So I will be a gastroenterologist. Some people do choose to do both, but you spend an extra 3 years or 2 to 3 years getting this training. You're unlikely to practice general internal medicine. You're going to practice the fellowship that you've been trained for. But it's important to keep all the medicine that you've learned kind of somewhat in the back of your head, understanding that all disease processes are interconnected. And it's important to keep kind of the whole body in picture rather than just kind of approaching a patient with just your, fellowship view. I guess an example of that would be if, for example, someone came to me with GI bleeding, understanding that, okay, this patient has arthritis, they have joint pain. Okay, they might be taking medications that cause them to bleed. So it's important to kind of keep the whole picture in your mind. What other fields do you work with in gastroenterology? We work really closely with surgeons because a lot of what we do, for example, if we did a colonoscopy and we diagnose colon cancer, and that patient goes to surgery, they get their part of their colon removed, then they'll come back to us for surveillance to make sure that cancer doesn't come back at certain intervals. That patient will also go to oncology or the cancer doctors to make sure that they have chemotherapy if they need it, or if they have advanced disease, they need radiation, they work with radiation oncologists. So, we work with a lot of different physicians. We work with pathologists who kind of look at our cancer samples, who look at our biopsy samples and tell us, okay, hey, this person has a bacteria. Hey, this person has cancer. So we work with cardiologists. So you kind of work with almost every field of medicine. It's as we go forward in medicine, we're realizing how integrative medicine should be. We shouldn't just be within our own kind of fields, that to give the best patient care, we kind of all have to work together. So we have now multidisciplinary rounds where everyone gets together. For example, if we do cancer, there'll be a GI doctor, there'll be a cancer doctor, there'll be a radiation doctor, there'll be a surgeon, there'll be a radiologist, and we kind of all sit and we discuss cases and we come up with the best plan for a patient. And that's kind of the best way to approach patients. And you'll see that in kind of every subspecialty when you guys are getting into medicine, because it's important that to give the best care, a lot of people have to put their heads together. The worst thing about my specialty, the best and worst thing about my specialty. I wouldn't say this is the worst thing, but because I don't mind it so much, but it might be the worst thing to other people. There's a lot of poop involved and a lot of blood involved. So if you have a sensitive nose, it's not a good specialty for you. But I don't mind poop so much. I don't have a strong sense of smell. So it hasn't been a big issue. The best thing about my specialty is instant gratification, which you don't necessarily get with a lot of specialties. So for example, someone will come in GI bleeding and we go in with a camera test. We can identify the bleeding, we can treat the bleeding, and then they won't bleed anymore. Seeing them being sick and then get better, knowing that it's something that you did, is just a nice feeling. Is there any advice you have to someone who's thinking about going into the specialty you're going into? I would say make the decision early if you want to do gastroenterology. There are some specialties and subspecialties that are competitive and that require, good letters of recommendation, research, good scores. So it's good to have an idea kind of early on whether that's something you're interested in, so that you can kind of gear your application to that. So for me, I made the decision. I came into fellowship residency considering GI, and then made the official decision by fall of that year and got involved in research by December of my intern year. What is the benefit of having a gastroenterologist perform endoscopies or procedures over other professions? So that's a good question. So right now, surgeons can also do endoscopies, and I think there's some training programs for advanced practitioners, so nurse practitioners or PAs to do them as well. I think at the end of the day, it all comes down to number. The more procedures you've done of a specific type, the better you are at it and the better outcomes you have. That's just what the data shows. So, when we graduate from fellowship, we do anywhere between 500 to 1,000 colonoscopies. So you can imagine that you're pretty comfortable with colonoscopies. Whereas, surgeons still do them. They have different numbers. Their numbers are a little bit lower. So it really just depends on how many you do. That just kind of correlates with how your complication rates will be. So I think it's more important, not necessarily what profession somebody is, but maybe more so how many they've done. How has COVID affected your work since you have less surgeries? So yes, that was a big deal. When COVID first hit, it was a statewide mandate. Everyone had to stop doing non-urgent procedures. So there was a time when there was no procedures being done. And then as we restarted, we had to practice social distancing and all these things to make sure that we weren't spreading COVID, because endoscopy is aerosolizing. So we had fewer procedures in a day as opposed to how many we really had. Now we're back to our previous kind of numbers. So there was a dip, and it did, some of the things there's a lot of patients that have built up in the meantime that need their procedures done, and maybe some delays in cancer diagnosis because of that. So there's a big surplus of procedures that need to be done now. Do you deal with morbidly obese patients? If so, what are some things you would suggest patients do? What path would you take to help the patient? Sure, that's an excellent question. So obesity is a multifactorial disease. It is, no one's fault. There's a lot of things that go into weight, and that has to do with genetics. It has to do with our current nutrition system, patient socioeconomic status. So I think it's really important to first make sure that you take the blame and the judgment out of managing patients with obesity. Then I would say having access to a good nutritionist or registered dietitian is really important. Understanding how someone eats. Are they emotionally eating? Is there any eating disorder involved there? What else is going on? So taking a good history of kind of everything that's going on, their disease processes that they have, their medications that they're on that might be causing obesity, and kind of tackling that. After that, there's 3 options really for patients. There's medications, which are effective. You can lose about 5 to 10% of your estimated or your total body weight. Then there's surgery, which is the best kind of gold standard for weight loss for patients that meet the criteria. And then there's a new area, endoscopic bariatrics, which are great for patients that don't necessarily meet the requirements for surgical weight loss. So I would say the first step is obviously diet and exercise with the help of a registered dietitian and a physician that's trained in obesity. Then I would consider, talking to the patient and seeing if they're interested in medication, endoscopic bariatrics, or bariatric surgery. And that's kind of the path that I think of. And a lot of factors depend on where I would send a patient. Have you been in cases where you were not able to find the problem that a patient is having? Absolutely. This will happen to everybody in some point in their career, where I'll give you an example. We have a lot of patients that come in with low blood counts, and we just cannot find the source of bleeding. You do a camera test from the top, you do a camera test from the bottom, you do that pill that you swallow, it takes 10,000 pictures, and you just don't see a bleeding, because sometimes these things are intermittent. A blood vessel will bleed, then it will go away. You don't find it. And so it's not uncommon for these things to happen. That being said, keeping in mind that you have open communication with the patient and say, hey, this is what's going on. We can't figure it out. This is what you do when this happens. If your blood counts are low again, we're going to give you blood. We're going to give you fluid. We're going to do this. Look with these camera tests and understand that we may not be able to find anything. And usually patients understand if you talk to them and kind of have a conversation with them. What tips do you have for high schoolers? Okay, so yeah, a lot of my tips here are mostly college and medical school. In terms of high school, I would say, your focus there is really just getting into college, making sure you're getting into the college that you are interested in. Sometimes, if it's the right decision for you, you can consider 7-year medical school programs, or the programs where they kind of roll into a medical school from undergrad into med school with not as high of a MCAT cutoff as other places. So that's an option for you. It's definitely something to consider. My husband went to a program like that in New Jersey, and I know he had a very positive experience. That being said, your primary goal is to just get into a college that you're interested in, that has a good program for the major that you want to do, and you're able to do your medical school requirements, whatever that may be. But I would say that's kind of, you're just setting up your application for college. What does your daily schedule look like? So right now I'm on endoscopy. So my cases start at 7 and they end at, the last case is at 4. So, usually that means I'm done with my day about 5:30. I have conference in the morning, and that's kind of what my typical day is now. When I'm on inpatient, I start the day by seeing patients, and then as new patients come through the ER or patients have bleeds on the floor, I see those patients in the afternoon, and then I do cases after that. What diseases do you most commonly investigate as a GI? Usually it's, for me, GI bleeding, colon cancer, but some other things we see, foreign bodies of people that swallow things they shouldn't, and then they get stuck somewhere in their GI tract. People who eat food that gets stuck somewhere in their GI tract. Different kinds of malignancies, anywhere from top to bottom. Motility issues, diarrhea, constipation, heartburn, dysphagia, so when food gets stuck, pain on swallowing. So a lot of things like that. It is easy to do all of your pre-med requirements by medical engineering. I will say that it did not help my GPA doing biomedical engineering, but in terms of work ethic and knowing how to study, things like that, I think your biggest thing in college is you're kind of trying to find out the best way that you study, whether that's flashcards, whether that's note taking, whether that's pictures and pictograms to help you memorize things, because in medical school, you're drinking from a hose. I mean, it's a lot of information in a very short period of time. So it's important for you in college to kind of identify the best way that you process information quickly. What major will be the most beneficial for medical school? Like I said, honestly, what major you pick really doesn't matter. It's what you're interested in. If, I wouldn't say, unless you're doing, there's not any particular major that I think really helps you for medical school. I mean, I suppose if you're doing biology, you'll have an anatomy class. If you have neuroscience, you'll have maybe a neuro class. But overall, the classes in medical school are going to be much more detailed and focused. So they're not going to be as helpful for you. I don't think the most beneficial thing you're doing in undergrad is learning how to study. What major is best for gastroenterology? There really isn't one, I wouldn't say. I guess if you did nutrition, maybe it would help you from that standpoint, but it's really something that you'll pick up in medical school rather than undergrad. Yeah, so I don't think there's a particular major that's going to help the most for any particular field of medicine. That's all the questions. Okay, so we'll go through some cases and you guys can kind of just keep popping in questions. This first case is a 50-year-old female with past medical history of osteoarthritis on ibuprofen, coming in with black stools, lightheadedness, and dizziness. Their vitals, which are something that people will take as soon as someone gets into the hospital. So their heart rate is 110, and normal is going to be less than 90 for the most part. Blood pressure is 90/60, which is low. Hemoglobin is 6.8. Your baseline is usually around 14. Iron is 4. Iron saturation is 8%, and ferritin is 10. So that's all low. It's indicating iron deficiency anemia. And the rectal exam shows this here, which is black, tarry stool. So what does that mean? So for us in GI, a rectal exam is one of the most important exams that you can have and you can do on a patient. And what you're looking for is you're looking for stool. You're looking at the color. Oftentimes when people come in through the ER, they'll tell you that people are having dark stool or they're having blood. And the color of the blood is very important to us because it tells us where the bleeding is coming from. So melena, which is dark tarry, that's that picture you see here, tells us it's an upper GI bleed. So it's in their esophagus, their stomach, or small intestine. Bright red blood or maroon blood often tells us it's lower, so your colon. So that's not always the case, but more often than not, that's kind of what tells us what procedure we need to do to look for the bleed, whether we need to do an endoscopy or colonoscopy. So a rectal exam is super, super important. Okay, so this person was sent to the ICU. They were resuscitated, so they were given intravenous fluids and blood products. And anytime we're giving blood, our hemoglobin or blood counts that we target are going to be greater than 7. They were started on a medication called pantoprazole, which helps form clots to stop bleeding. And their medication was stopped. So this patient had arthritis and was taking ibuprofen, which is a type of NSAID, which you will see in Advil, Motrin, Aleve. A lot of these medications have ibuprofen in them, and they can cause GI bleeding. They're not benign. So it's very important that you avoid taking these medications in high doses. And we went in with a camera test, an endoscopy, and we went in, we saw this picture here. So what you're looking at here is this is an ulcer, and essentially it's eroded the lining of your stomach to the point where it's hit a blood vessel and exposed it. And this blood vessel is shooting blood into the stomach and filling the stomach with blood. And for us, it's a very scary thing to see, especially when you're starting out in GI, because it can fill up your stomach pretty quickly. So we can treat this. We inject medication that can temporarily stop bleeding. Then we can burn the blood vessel, we can clip the blood vessel, and we can band blood vessels. And these are all techniques that we have of stopping bleeding. The second case I'm going to go through is something else that we see very often. And I'm going to end it with, I should have put this picture in, but I'll tell you the story. So this is a 25-year-old female, past middle history of schizophrenia, coming in with dysphagia, which means that food is getting stuck when they swallow, or odynophagia, which is pain when they're swallowing. But they're able to tolerate their secretions. So all their saliva is going down. And we get an X-ray, and it shows a metallic tip and a plastic casing in the stomach. So essentially, this patient swallowed a pen, and it is sitting in their stomach. So we, make sure they're not eating anything after that. We put a tube in their airway to protect their lungs, and then we go in with our camera test, and we go and retrieve objects. So here you can see that someone has swallowed a razor blade. This is a pen, and this looks like a piece of plastic serrated knife. So we see a lot of things. I think some of the craziest things that I've pulled out of people's belt buckles, part of their glasses, scissors. I've seen someone break scissors and swallow them. So definitely something interesting that we get to do. The patient that I wanted to tell you about is, we had one recently where somebody came in with a rectal anal beads that had gotten stuck in their bottom that we had to pull out using a colonoscopy. So we see some crazy stuff, definitely entertaining. And case 3, this is the last case I have. This is just something that we see. It's very commonly seen by us. So a 60-year-old gentleman with no past medical history, having weight loss, rectal bleeding, and constipation. His hemoglobin is 7.1, which is low. He's also has low iron. So that tells us he's losing blood somewhere, and likely in his GI tract. We did a rectal exam, and this time it showed brown stool, because this type of bleeding can make intermittent. We did a colonoscopy and we saw this picture here. And what you're looking at here is a large tumor, and this is cancer. This person ended up going into surgery. So one of the most important things we do as a gastroenterologist is we screen people for colon cancer. So regular intervals, we'll have them get a colonoscopy. So currently, all the guidelines agree that everyone should get colonoscopy starting 45. And based on what we see, they get a colonoscopy interval screening after that. And if we see polyps, we will take them out. Okay, that is the end of my cases. Does anybody have any more questions?
It looks like that's it for the questions.
Awesome.
Thank you so much for today's session. That was really amazing. I definitely learned a lot.
Oh, good. I'm glad. If you guys have any questions, feel free to contact me.
Thank you so much.
Thank you. Thank you. Have a good day, everyone.
Bye-bye.